Good morning, everybody. Thank you for coming on your the weekends, that a precious time for everybody. And it's my pleasure to talk about the topic of pulmonary hypertension, which for many of you will be somewhat unfamiliar territory. And as both Anne and Michael have mentioned, a lot of the focus for heart kids has been around congenital heart disease, which does cross into the condition of pulmonary hypertension, but is certainly something on its own to be explored further. So from a historical perspective, it's probably not something that many of you have come across, and it's actually not something that was even really talked about until about 60 years ago, when there were about 30 cases in the USA that a scientist discovered and termed the frame of primary pulmonary hypertension. It was in adults that did not have congenital heart disease, but had a primary form of the condition where they couldn't find any other cause of why they had this abnormal condition. And since then, without going into too much detail, there have been meetings to discuss and classify the disease further. But it was only, 20 odd years ago that, or 20 years ago generally, that the survival was very poor in this age group. And since 1999 we've had our own service here, and this delightful young girl that was on the front of the Herald Sun back at that time was a 5-year-old girl that we really couldn't offer a lot of therapy to. And fortunately, because of her fantastic parents and media exposure at the time, it was really the impetus to start our pulmonary hypertension service here in Melbourne. And we were the first centre in Australia to offer this program purely dedicated to the needs of these children and families. Since then, the demand's escalated. And we've been fortunate enough to have some treatment options become available in Australia, and so we continue to support families with varying forms of pulmonary hypertension. And our overall goal is to promote excellence, clinical expertise and evidence-based practice in management of these children. So most people in the room will really be thinking that this is a heart condition, and that it is, but what we need to remember is that is primarily a condition that has its basis really in the lung vessels. And so it is a progressive and unfortunately life-threatening disease characterised by very high levels of pressure in the lungs. The lungs are used to very low pressure flow through them. But what happens when you've got some abnormal circulation related to congenital heart disease, or perhaps some prematurity and lung disease, or possibly just at risk from a genetic predisposition, it causes these lung vessels to unfortunately have some abnormal development and cells that cause inflammation and some tightening of these blood vessels, then impact back on the heart. And that is why we tend to manage it in the cardiology setting. We see when these patients present to us, they're usually compromised from a cardiac point of view, because the right side of the heart that's used to generating pressures towards lungs with fairly low sort of pressures suddenly have a lot more resistance and hard work to have to deal with. And it's the heart muscle, like any other muscle in the body, that has to get bigger and try to cope with this. So as I touched on, there are primary forms of pulmonary arterial hypertension where there's no apparent cause, and we expect it, or it seems to be a genetic sort of basis. But then there are other variations of the disease related to lung disease, persistent pulmonary hypertension in the newborn that is dealt with in our neonatal unit, congenital heart disease and other inflammatory disorders. And without treatment, the disease in the past was fatal, but in the current era, treatment survival has markedly improved. So, as is the case with all of you that have a child involved with some sort of heart condition, it's a challenge to be conquered with determination and commitment, and that's a team approach from the parents and also the health professionals involved. just to give you a bit of an education about this, mouthful term, pulmonary arterial hypertension, the trickiness of diagnosing some of the patients that might not present as newborns or in the post-operative course after some congenital heart disease intervention is that the symptoms you'll see there are pretty general, and most days I might tick off a few of them myself, but these little babies or children have this insidious sort of condition that really often doesn't present until they've got a fairly moderate form of the condition. And as you would expect, things like shortness of breath, being a bit pale, tired, being a bit short of breath, are things that in the community are often put down as asthma and other more general sort of things. And so the challenge in the community for the physicians and, generally just people like yourselves is that it's not a common condition. There hasn't been a lot of exposure about it. And so, some of these children are labelled as having asthma and other things. And so they sometimes don't make their way in until they're in a fairly advanced state, and that's a challenge. I won't dwell on the diagnostic workup, but just to sort of know that for some children and families, the journey of having this condition can be a fairly abrupt sort of presentation where they might have eventually or sometime been referred in to us, and we start talking about all these big words, and then they've got to have all these tests, and it's not as simple as just having one, like just having the echocardiogram or just having the ECG. It's a matter of us exploring all of these tests that some of you will be familiar with and excluding other things and other causes. So it will exclude other things that might not be pulmonary hypertension, but it also gives us information about that this pulmonary hypertension scenario they're showing might be related to congenital heart disease or a liver condition or such. And so it's a big deal. It often takes a few days for these families, and it means them being inpatients, and it's a tough time. And at the end of the day, then we really are just able to sort of say, yes, this is what we have or haven't found. And look, the right heart catheters aren't always done because that's a big deal. But if the team decide that that's not too risky, then that is really the gold standard to diagnose this. So as I touched on, it can be fairly non-specific symptoms, and the formal diagnosis is made on exclusion of workup tests. It's an often gradual onset of the disease unless they present as newborns or immediately post-operative surgery for congenital heart disease. It's got a pretty low incidence, so not a high awareness in the community, and in the primary form of it, where it's not related to a heart or lung condition and so forth, we do screen other family members, and that's particularly stressful for those families that are not only dealing with that child but have the potential for other family members to be involved, and it's something that is ongoing. So even if we tend to screen the siblings every couple of years in the primary form, not other areas of it, but they might come in and they're fine, but we have to keep checking that every couple of years because it can progress, as some of you in this room would know. I won't dwell a lot on the treatments, but just needless to say that a decade ago we had very limited treatments, and the girl that we showed at the front that was on the newspaper, she really did start some access to a very expensive therapy at the time that was supported with the state government and the pharmaceutical company at the time. But really there was nothing properly listed through the pharmaceutical benefit scheme until around 2004, and since then we've been fortunate enough, usually on the background of adult studies, to have available therapies come our way for children in Australia, and so there's much more targeted therapy. There's oral tablets, there's intravenous medication, which of course is a big deal, but and then there's all the more general adjunctive therapy, and needless to say that lung transplantation is a possible intervention. But in this era, now that we've got treatments, we tend to see better outcomes with using those. But if that becomes exhausted, then lung transplantation may be a consideration. So that's pretty much what I've said, just that we've had significant advances over the last decade, and such disease-specific pulmonary arterial hypertension therapies have improved things such as exercise, functional sort of day-to-day living, quality of life and survival. This is probably a little bit more than, unless anyone's, there's a few that will be familiar with this in the room perhaps, but the biggest commitment and the most stressful treatment for families with some of the conditions of pulmonary hypertension is the intravenous therapy that is a continuous infusion of a very potent drug that induces sort of relaxation and relaxation of the lung vessels and relieves this problem. But you know, it's an enormous thing where parents are under stress, having to make medication under relatively sterile sort of conditions every day, manage a central line, attend to their child's dressing and so forth. And of course there are adults with this as well. But the positive thing about it is that we've got children that have been on this for up to 13 or 14 years now. And at the time of, when they started, there was a survival that was much, much poorer than that. And, it's pleasing to see that some of them are grown up and transitioned into adult care, and one of them in particular comes to mind and is working as a nurse here at the Children's Hospital and has this pump still running, every second of her day here. So it's a pretty big deal. So what does it mean for the families of these patients? Like yourselves, we provide ongoing support and care of the chronic health needs in our community, as we do for all heart conditions. There's attendance of regular outpatient appointments. We manage the acute care patient health issues as inpatients, and we try to optimise management to suit the family lifestyle and allow these children to attend school, kindergarten and so forth in the community by offering as much support as we can. And what that means is, from a nursing point of view, that we provide comprehensive resources and frameworks for staff, but also for families. And we're in the process, my colleague Bronwyn and I are in the process of putting together a package for patients with this condition with a lot of information that they will be given from the time they're diagnosed. The hardest thing, I think, is really supporting these patients through their journey, which, is a matter of just navigating through fog some days more than others. And it's not a predictable condition, as a lot of heart conditions aren't. And so that journey from the time of diagnosis and beyond is a tricky one. And we do our best to support with emotionally and with counselling and social support. In doing that, we're, as Michael mentioned, and from support of Heart Kids and the like, we've been able to pursue furthering our understanding of this relatively new condition really over the past decade, and formalising protocols and guidelines which we're pleased to say are used nationally, as more paediatric centres have set up their own pulmonary hypertension programs, and also with adults. And I've been fortunate enough to have the opportunity to set up a dedicated database for children with the condition around Australia and New Zealand that I'm writing up manuscripts at the moment for, as well as that being the foundation for some an adult registry for congenital heart disease in adults with pulmonary hypertension that has already had some publications. So, there's a lot of really interesting information coming out about describing the population we're dealing with, but also looking at what treatments and sort of outcomes we're getting in Australia and New Zealand. We've now got the opportunity to have access to some targeted therapies, which we haven't always had. So that's very positive and encouraging for families, and we support all of the ongoing administration of those. And it's really about a matter of collaborating with all of the healthcare team for these patients, and that obviously goes for, you know, whether it's with pulmonary hypertension or other conditions in cardiology. So we try to address the needs of patients, including continued evaluation of their therapy, health promotion in the community, and we deal very closely with our adult colleagues at the Alfred Hospital and other interstate centres about collaborative care and the best outcomes for these patients. I think I can move on from that. Just to touch on the congenital heart disease here. It's an increasingly complex group of patients that are surviving with pulmonary hypertension associated with CHD. And we know that it doesn't originate and progress in the same way as the more primary form of the condition that really we dealt with more so 10 years ago. And now each of these patients that are coming along are being individually assessed, and some treatment options are being may be available and considered for those. But needless to say, there are a wide range of physiologies with pulmonary hypertension associated with this, ranging from candidates for Fontan procedures who have low pulmonary vascular resistance, which is not low enough to operate at acceptable risk, and to intricacies of left heart pulmonary hypertension and different types of fixed circulation with Eisenmenger syndrome. So it's very complex, as I'm sure you'd understand. But the good thing is that we're seeing progress, and we're expanding the healthcare needs of these families. We're getting referrals from other teams about children, and able to offer them some fairly focused therapies. It does remain, in real terms, a very challenging condition. We've still got in more than about 50% of patients exercise capacity that remains quite impaired. Some patients continue to have numerous hospitalisations, but fortunately a lot of them we are able to manage in the community and only see intermittently at clinic review. Right heart function remains significantly impaired in many patients, as is quality of life. So although there's been huge improvements, we can't forget the enormity of this condition. So we need to continue to aggressively pursue furthering our understanding of pulmonary arterial hypertension by bridging the gap between theoretical and practical care in the current health system, and to appreciate the real life experience of patients with this condition. And regardless of the treatment pathway, children with pulmonary arterial hypertension undergo lifelong therapy, requiring care from time of presentation through diagnosis and the entire life journey, which is the same with all of your children. And with the commitment and resources that we have backing us with, Heart Kids, MCRI and so forth, we feel we can get there, but it's the courage from the parents that really make the difference, and ultimately the children. Thank you for coming and seeing our lovely hospital, and enjoy your day.